All right, well, good afternoon. I'm pleased to introduce our symposium, Disclosure of Serious Mental Illness in the Workplace, with Marjorie Baldwin, Stephen Marcus, Renaud Batis, Suzanne Briere, Ann Hirsch, Nev Jones, and Marjorie Baldwin at the end, again. So with that, I'm going to just turn it over, and looking forward to this.
All right. What do I need to do here? I kind of feel like I should be talking to you guys, too. It's like, I am excited to be here for two reasons. Not just one reason, two reasons. First of all, the obvious reason, which is I really believe that this topic, disclosure of SMI in the workplace, is super, super important. But second, the reason for excitement is it represents, this meeting here today, I think represents a milestone in the work that we have been doing for probably about a decade. And it is a testament to persistence of trying to convince the NIMH Services Research Committee that this is an important topic. I will say our submission of an R01 on this topic 6 times is really reason to believe that there is always hope, and that if you keep at it long enough, you can be very convincing about what it is that you believe the field should be doing. But a shout out to Mike for being so supportive. It really has been a remarkable help. So, what do I push? Oh, here.
There's a thing. Did you just do page down on there?
Where's the thing? The arrows? Okay, the arrows.
Here's the thing. You wanna...
Oh, the thing, all right. So what we're talking about when we talk about competitive employment, we need to be specific because there's been a lot of confusion with the work and the grants that we've been doing and confusing competitive employment with supported employment. And so by competitive employment, we're talking about jobs that pay at least the minimum wage, they're not set aside for people with disabilities, and they're not obtained with help from mental health professionals. And competitive employment should be understood within the context of gainful employment, right, which is sufficient income to support yourself. It's questionable whether minimum wage is that, but that's a different issue. But you aren't being supplemented with disability payments. It's an important distinction. And most importantly, I think, employment for people with SMI is probably one of, or not the, clearest sign of recovery from SMI, to be engaged in gainful work. I mean, like all of us. All right. So when people are having SMI and they're in the workplace, they have a choice about whether they want to disclose their SMI to an employer. It's a difficult decision. But if there's a need to get accommodation, that they need help to succeed in their job, they need to disclose it. And if they want to gain the rights that they have under the ADA, disclosure is required. But it's tricky. It could be good. It could be good that it's empowering to be able to tell people about it. You could get accommodations that help you succeed in your job. You can get support from your coworkers, but it's a risk. There's still a lot of stigma around mental illness, and discrimination is possible, in fact, very possible. Harassment, job loss, or if you're trying to get a job, not being able to get it. So, there's a lot we don't know. We don't know about competitive employment in general for people with SMI. We know even less about disclosure among people in competitive employment with SMI. We don't know who is disclosing, what they're disclosing, when they disclose, or how or why. And these are all important questions that we need answers to be able to really effectively implement any sort of engagement with employers or persons with SMI to make the work experience successful. But we do know some things, and I would go so far as you could write a book about it. And we have in our presence a shout out to Dr. Baldwin, who has written a wonderful book. I just have to give a plug for it because it's so cool. It's a book by a labor economist who has synthesized the literature about why people with mental illnesses fare worse than pretty much any other group in the labor force. But it's written scientifically, but also from the perspective of a mother with a son with schizophrenia and David's experiences in the healthcare system and in the workplace, and how to really combine those two parts, scientist and a mother, in really what is just a fantastic book. So, A+. Today, we are going to hear 4 great speakers, and I'm excited to hear these. We're together as a team for the first time here today. It's exciting. So Suzanne is going to be talking about policies that affect people with disabilities in the workplace. Anne is going to be talking about potential interventions and ways to successfully, from the employer's point of view, accommodate workers with SMI. Nev is going to share with us, Nev is going to share with us some work from a qualitative study of hers where she interviewed people with SMI and their trajectories for success in the workplace. And Margie is going to talk about pilot data that she and I did for our preliminary work for the R01 that we're working on to do understand SMI in the workplace quantitatively and how people disclose or don't disclose. All right, I was going to do 5 minutes. I did 7 minutes and 45 seconds, so not bad.
Is it already up? Where is it on the bottom?
If you go to the P.
Mm-hmm. Should it be all queued up? Yeah. Okay, great. Thank you. And then I need...
Slideshow from beginning.
Okay, great. Thank you. Thanks for the opportunity to Margie and Steve for sharing our work in the context of what these very critical issues, as Steve has laid out for you. I'm from the Cornell University School of Industrial and Labor Relations. It's a college for the workplace. And in this college, we have a number of institutes related to a wide variety of workplace issues, one of which is focused on employment and disability, the K. Lisa Yang and Hockey Tan Institute on Employment and Disability. And I serve as the director of that institute. And that's a great picture of Cornell in the 2 weeks we have spring, in June, usually. Otherwise, it's a lot, well, many varieties of white, probably 6 or 8 months of the year. I want to acknowledge, and in fact, I said 2 grants from the National Institute on Disability, Independent Living, and Rehabilitation Research in Health and Human Services. But actually, as I thought about some of the work I was going to present, it's really 4 grants. We have had 2 field-initiated grants, one on social networks in workplaces and one on use of the Equal Employment Opportunity Commission data to take a look at the charge data for people with disabilities, as well as an Employer Practices Rehabilitation Research and Training Center and an Americans with Disabilities Act Center, Northeast Center, one of 10 centers that NIDR funds. So in the time I have with you, 10 to 15 minutes, I'm going to talk just a little bit to set context about the regulatory environment very quickly, on non-discrimination protections and accommodations in case people are not familiar with them. I'm going to specifically call out a little bit from our analysis of the U.S. Equal Employment Opportunity Commission charge data with a disability focus, some of the charges that are evident for people with mental illness, mental health related issues, and focus on the topic, the importance of disability disclosure, drawing from a variety of sources of data, some case studies, some national survey data of human resource professionals, and some deep dives into companies. I'm going to highlight the supervisor role, which one of our studies focused on, and its importance in the experience of people with disabilities. And again, from our EEOC data case notes, talk a bit about stigma and stereotypes that people experience and how that impacts them. And then leave you with some references and resources. I might say that the work I'm citing, for the most part, really was more broadly looking, has been more broadly looking for 25 years at workplace policies and practices that facilitate inclusion and minimize discrimination for people with disabilities. I've called out those things that we particularly could speak to around mental health, but I broadly believe that many of the good practices that we have identified over the years really relate to all of these populations, and people with mental health disabilities would equally be, if not more so, advantaged if we had employers doing some of these things. So a little bit about the regulatory environment. As many of you are probably aware, the Americans with Disabilities Act was passed in 1990. The employment provisions came into effect 2 years later. And so we have data from 1993 that we used to look at claims. An important part of that law is the reasonable accommodation provision, which is defined as assistance or changes to a position or workplace that will enable an employee to do his or her job despite the fact that they have a disability. So the employer, at the request of the individual, where disclosure occurs, responds to try to facilitate something that will maximize the individual's ability to participate and be productive. It does make the provision that these are qualified employees. The employer does not have to retrofit or change a job specifically for the individual, especially if it would be an undue hardship. An important change that occurred and is relevant to this discussion today is that certain case law had narrowed the definition of disability, and so many people were falling outside the net of protections and being discriminated against. And so in 2008, there were changes made that, again, redefined the disability and broadened it, making it easier for an individual seeking protection under the ADA to establish that he or she had a disability within the meaning of the ADA. So you're going to see me looking at claims around from that just before and after that time period, because we were looking to see if things changed over that time period. An example of the narrowing of the provision that was corrected by the 2008 amendments is that if a person's disability was mitigated with medication or some other kind of accommodation or alternative technology, that person would no longer be a protected person. So people whose epilepsy or other kinds of disabilities or perhaps mental illness was presumably under control by a medication, that person could fall outside the net of the protections and be discriminated against under the provisions when they were narrowed. So, examples of accommodations. I'm not going to dwell on this because my colleague who's going to follow me is going to spend a lot of time giving you some really terrific in-depth information on examples of accommodations. But just to put this in the context of the ADA, what we're talking about for persons with mental health disabilities, flexible work schedules or start times, and that this kind of a need comes to advantage many of us in the workplace, not just people with disabilities, and not just persons with mental health disabilities. Reduce distractions or noise in the work area, working from home or telecommuting, written instructions and task lists, regular written or verbal feedback, flexible break schedules, private quiet space to rest during a break, and use of a job coach. So all things that can help, not an exhaustive list, but illustrative of some of the things an employer could consider. Whoops. I am having some kind of anomaly with the data. What I can tell you is the percentage you should be looking at is 14% on the left, 86 on the right. And so the percentage of charges over this time period here, and again, 2005 to 2014, because we were looking at changes pre and post the ADA amendments. So approximately 1 in 7 of the charges, a total of, in this case, almost 360,000 charges total over that time period, were ones that related to a diagnosis of a mental health-related issue or disability. I am so sorry. I'm not sure why this is coming up this way. But obviously you can see the trend lines. It goes from, I think it's around 13% to almost 16% increase in mental health-related charges before and after, or increasing over the course of this time period. And as you can see, there was quite a jump in 2008, which is interesting for us to look at, because it would say that those changes, people took notice of them, they were aware that now they were protected people, and more people came forward, particularly people with what we would determine were non-apparent disabilities. More people were coming forward after the ADA amendments took effect. Mental health basis on the ADA charges, depression, and I will need to go back and look at my own notes to be able to tell you the exact numbers on this. I don't have them in it. But depression, obviously the most prevalent. Other, an aggregate across many mental health-related disabilities. Total across the same time period, above 50,000. Manic depression, PTSD, and schizophrenia, the least, and that is a disability we're talking a bit more about today. The disability charges for the EEOC have both the types of disability that the claimant is saying that the discrimination occurred on the basis of, and also asks about the part of the employment process, which is really helpful to us to understand where employers are stumbling in their treatment of people with different types of disabilities, including mental health disabilities. And over the course of the 28 years since passage of the ADA, it discharged, and this is true also for other types of employment discrimination, discharges far and away the highest, most often, about approximately 50% of charges, followed by reasonable accommodation, by terms and conditions of employment, by harassment, by discipline, and by constructive discharge. And constructive discharge is the person is being put in a situation where they have no alternative. The workplace is making them so miserable that they are forced to resign. So those are the conditions in which people are experiencing discrimination and making claims. I also thought it would be helpful to illustrate the issues of stigma, which I think we will probably talk about further in each of our respective presentations, that actually came from case notes. So we went through many case notes to take a look at more specificity, which the claims data doesn't give us in the quantitative analysis. And this is illustrative of some of the things people experienced: being forced to share information beyond what is required for an accommodation request, so they feel like they have to disclose too much about their mental health disability, being forced to tell coworkers about the mental health condition, and subsequently to disclosure disparaging remarks made referencing their disability. The individuals were called names or ridiculed, berated in front of others, and are treated as if their mental health issues impacted their ability to do their job. Hostile remarks or actions by coworkers or supervisors, such as attempts to marginalize or isolate the individual by taking away clients if they have a caseload of some kind of customers, sabotaging their work, and setting meetings when the individual was unable to attend. So that's a bit of the qualitative data that we were able to cull from the case notes. Here is a summary of the discrimination charges more broadly. The annual number of discrimination charges has risen 14% of the charges were mental health. The yearly percentage has steadily increased, 13 to 15%. These are some of the statistics you were not able to see on the individual slides. Depression accounts for most charges, 1 in 3, followed by anxiety, 1 in 4. Most common cited employment issue is discharge, 3 out of 5 charges. I was saying 50%, it's actually a little bit more, followed by accommodation, which was approximately a third. Being able to effectively welcome and include individuals with disabilities into the workforce, therefore, is a really important part of this process. So working on workplace culture, important for all of us, but particularly for this population. We have lots of education we need to do. One of the things we have found iteratively over many different types of data gathering experiences is how absolutely critical the role is of the supervisor. And I think any of you who've had supervisors would agree they make or break our experience in a work day. And we found that this was particularly important for people with disabilities because where disclosure is concerned, it is the place where disclosure is more likely to occur, even more than human resource professionals, which we thought would be the place where that disclosure occurred, but it's not. It's supervisors, where that more intimate relationship provides a forum. People feel that they may more safely disclose, and yet supervisors are really ill-equipped to deal with this effectively. So it's important because that's where it occurs. Education needs to occur. I'm referencing the third bullet first, because managers are key to the quality of the workplace experiences for people with disabilities as they are for all of us. And another interesting nuance we found, there was a decided difference from surveys we did of workplaces in asking questions like this. When the manager was told that they have a responsibility on disability inclusion, that was because it was strategic imperative of the organization and because the organization valued this kind of difference in inclusion, far more effective than if they said, we gotta do it because the ADA tells us to. Completely changed the headset of the supervisor and the experience of the individuals that they were supervising who were people with disabilities. So that messaging is really important. We do know when we were able to look at factors in the workplace where we had a litmus of workplace inclusion indices from employees and from supervisors, that when individuals with disabilities are in what we would define as inclusive climates, they report greater success in having their accommodation requests granted, greater coworker support of their accommodations, better experiences of procedural and interactional justice during the accommodation process, lower levels of harassment and discrimination, their own and across the unit, higher organizational commitment and satisfaction, and lower turnover intentions. We also, in a separate survey of 600 individuals with disabilities, asked them when they would disclose, and we found that the factors that would support that, encourage that, was if they needed an accommodation, makes perfectly good sense, if they have a good relationship with their supervisor, or if they perceive that this is a disability-friendly workplace. And some of the things that they would cite were like they saw active disability recruiting, that disability was in the diversity statement. Other things that might, about half of them, or 2 out of 5, half knowing of other successes. Somebody else disclosed, it didn't seem to change how people perceived them. They felt more confidence. Or if they felt that there were affirmative career development programs and that they would be identified with a cohort that the company was actively trying to promote within the organization. Then they might come forward. Reasons why they would not. About 3 out of 5 said a risk of being fired or not hired. 2/3 employer may focus on disability, risk of losing health care, fear of limited opportunities, supervisor might not be supportive, being treated or viewed differently, or if it wasn't going to make any difference in terms of what happened to them on the job. Only 1 in 4 approximately said it was for a desire of privacy. So it was more a fear of negative impact and perception or actual outcome. Some of the things we encourage employers to do is to use their employee assistance programs, which are not always well geared up to deal effectively with these kinds of situations. Train supervisors, managers, as well as union reps, HR consultants, and the general population about the importance of good mental health in general in the workplace, but really inclusion of people who have the experience of a mental health condition in the work environment. Do stigma awareness campaigns and clarify responsibilities in terms of accommodations and how that fits in with existing return to work processes. So in summary, the ADA provides a framework for employment of persons with disabilities. What most of the focus is on accommodation, and historically has really been more for physical disorders, I think in general, in sheer numbers of our focus, than for mental health. There's a huge need here. Organizations have to change to recognize that many persons with serious mental illness are capable of working and welcome them into the workplace and support them once they're employees and they may have an incident. Solutions involve both individual and organizational approaches, and the employers play a critical role in that. They need to address stigma and inclusion, and it needs to be a multi-level approach, engaging individuals and key organizational units and leaders. And we have a variety of references on some of these resources from our research, including a free online benchmarking tool for employers across the good practices and across the employment process. And I will stop there. Thank you for your attention.
Thank you, Suzanne, and thank you again to Margie and Stephen for inviting Jan to participate in this wonderful forum as well. Now I got to master the technology.
Does it go down to PowerPoint?
Right.
Yep, and then you should see your name and the microphone.
Okay, thanks.
Just click on it.
I thought I did. No. I have some skills, but
PowerPoint.
okay, there we go.
You should see me with Excel. Not in a good way. Go to slideshow at the top.
Thank you. And I'll get started. My name again is Ann Hirsch. I'm one of the co-directors at an organization called the Job Accommodation Network, also known as JAN. JAN is funded by the Office of Disability Employment Policy. They're part of the Department of Labor. Just to give you a little bit more about JAN and who we are and my perspective, we've been around for 35 years. Since 1983, we're housed at West Virginia University. And we handle about 46,000 contacts per year. And what I mean by a contact is people call us by phone, internet, chat, email, and we provide the crux of our services to provide one-on-one consultation on all things related to reasonable accommodation in the workplace. What the options are, how to talk with an employer or a manager about it, or how to talk with the employee about it as well. So we serve both the employer and the individual as well as service providers, pretty much anyone who contacts us. 20% of those 46,000 contacts a year relate to a mental health issue. We're experienced, we've been doing this for quite some time because we're funded through the federal government. It's a free service for anyone who contacts us. It's national, serve the whole country through our office there in Morgantown, West Virginia. Very easy to use to pick up the phone, go to our internet site, so that's why I think we're quite busy. And most importantly, we're confidential. People don't have to give us their name to have a one-on-one consultation. A lot of people do, especially after they're talking to us for a while. But that's a little bit about where I'm coming from here. Down arrows should work, right? Or this. Right and left. Okay, thanks. I just wanted to touch briefly on some of the common mental health impairments that we hear about. Anxiety of all types, addiction, obsessive compulsive disorders, post-traumatic stress disorder, seasonal affective panic, or the three that are highlighted below are the SME examples that are in the research you're going to hear about next. We do hear from them as well, related to them as well, schizophrenia spectrum, bipolar, and of course major depression. Some of the more common limitations we hear about relate to concentration, memory, organization, time management, stress and emotions, panic, all things you would expect that someone might have as a result of a diagnosis on the previous slide. Just some real quick example solutions might be apps to help somebody with memory or concentration issues. We're seeing increase in apps that are being developed as well as being used, sometimes with the employer knowing it, sometimes not. Communication style is a big one that Suzanne referenced earlier, is especially with that supervisor, is modifying how that supervisor might bark orders and getting it done in writing. So sometimes the accommodation involves involvement with kind of training supervisors on good management skills. Okay. Some of the more common obstacles that have already been mentioned is that big disclosure issue, especially with this population. That's probably the biggest issue that we discuss is how, when, if, and how to do it, as well as that medical documentation. People are, for obvious reasons, really resistant to hand over medical documentation to an employer, especially a supervisor. Some of the things we hear from resistance from employers are modifying some of their policies, especially allowing service animals at work, although some are coming around and being a lot better at that. Reassignment to another position is also something that comes into play. We see a great deal around performance standards, and I'm going to get into that in some of my examples where people don't disclose until they get to that point, and that really makes it even more challenging to maintain that employment. Employers sometimes just throw up a red flag, oh, you got a mental health impairment, there's going to be a conduct issue. So we do a lot of training to try to get around and get them to better understand that issues. Job restructuring, confidentiality, misinformation about direct threat is something we're constantly trying to educate about. Okay, what I'm going to do for the rest of this presentation is just give you some examples, trying to hit some of those points and get a little bit more deeper into the types of accommodations. At JAN, we also do research. We do what we call the JAN study. We have a subcontractor that if somebody who contacts us, whether the employer or the individual with the health condition, we ask if they want to participate in the study. 6 to 8 weeks after contacting us, they're contacted by phone to see what happened after their contact with JAN. So the examples that I'm going to give you come either directly from that research, so they're real life scenarios, or from somebody calling us back and said, yeah, I spoke with you last week, I went to my employer, guess what they did? Hopefully it's something good. Not always. But in that research also we look at the cost and benefit of accommodation. And that's across all disabilities, but I can tell you from that research, employers tell us 59% of the time accommodations cost absolutely nothing. When there is a cost, that typical or median cost is $500. A lot of the examples of accommodations that cost nothing can be related to some of the things that I've already mentioned, like allowing someone to use that app that they've already downloaded on their phone, that change in supervisory method, the flexible scheduling that was mentioned earlier, things like that. Okay, let's get into some of the examples here. Here we have, Tilly has bipolar disorder. She needs to disclose her disability and ask for an accommodation. She knows what she needs is a flexible schedule while she adjusts to a new medication. She's having difficulty sleeping and waking up and has been late 3 days in a row. She's wary of disclosing her medical condition, but doesn't want to get into disciplinary action. So sometimes when people are contacting us, they're not really sure what they need, and we might make the suggestion of a flexible schedule, what's your work environment like, what do you do to try to help them understand what they can request. This is a frequent situation for individuals contacting us. They know they're struggling in performance. They expect a disciplinary action maybe coming down the road. It really puts them in a tight situation. So she chooses to disclose and provides medical documentation, and she provides very limited medical documentation so that she's not turning over too much information. And we have documents and forms and information from the EEOC on how to do that effectively. And her work doesn't depend on or affect others. Her employer found no hardship in flexing her schedule as long as she gets her time in between the core business hours of 8 and 6 p.m. So she did have a very proactive employer that was willing to listen to her and work with her. John here is a longtime IT employee of a university, discloses that he's been having severe bouts of depression that have affected his work on the night shift. And John requests that his shift be changed to help him better regulate his sleep. The manager is totally surprised because John has had no performance problems, and either John has been doing a really good job of masking his serious depression, or this manager doesn't recognize signs. It's nice to see some programs coming out through APA and other organizations and some of the larger employers where they're trying to draw focus on helping coworkers and supervisors and management staff recognize and know what to do if you recognize a sign of a mental health condition in the workplace. So what did they do for John here? The manager did ask him for his medical documentation and provided information as to why it was needed. They then took a look at the IT schedules to see what they could do to assist this On this previous slide, I think I said long-term employee, which is something that we hear about too, where sometimes there might be a little bit more success. In terms of that research that I did, the length of employment for people with the successful accommodations is, they've usually been there on average 7 years. Tanya, here's another one related to service animal, is a file clerk with an anxiety disorder. She has a service animal to help her deal with stress in the workplace. Unfortunately, I think with some of the issues in the media about service parakeets and other things like that, this issue has become more challenging for someone in the workplace. It's probably one of our top 5 issues that we discuss across the board. Try to do a lot of education of both the individual to help them become a better self-advocate, to know how and what to request, and to, when we're working with the employer, to make sure they're understanding what their responsibilities are. So this employer did modify its no animal policy and allowed the service dog in the workplace. One thing we always talk about with both the individual and the employer there is to have set expectations up front. Got several different documents on our website that help employers and individuals do that so that they can communicate it effectively. Just a couple more. Here we have a retired Army medic, had difficulty managing stress in the workplace due to her PTSD. Her stress intolerance was intensified when she heard the emergency medical helicopter arrive and depart from the hospital where she worked as a nurse. I spoke to this woman myself. She had been on the job for 3 weeks. It was her dream job. She was doing it. It was just killing her, and she knew she couldn't continue. She wanted to stay in the hospital setting. She had not disclosed, so I talked with her at length about how to disclose, what to disclose, requesting reassignment because she had already done a little research to know there was another position. She was reassigned so that she was far away from the helipad during times when the helicopter staff would practice maneuvers that she could hear from that work area. That was known in advance, so she could flex her schedule. She also told me that she was going to get back to that emergency room nurse because that was her dream job. I haven't heard from her since, and this was several years ago now, so I hope she has. Here we have one related to performance standards. A hotel employee conducts a meeting with Mina. She's a housekeeper to talk about her recent performance. This employer knows of Mina's OCD diagnosis, but doesn't mention it, the disability, and is prepared to handle the situation as a performance issue, which is something an employer should do, handle the performance issue as well, and gave Mina a verbal warning. Thankfully, Mina relates her low performance to her OCD within that conversation and asks for help in meeting that performance standard. But a lot of people don't know you got to ask for that help, and how to effectively relate it to your mental health condition. So I think just the education of what we do for individuals to become better self-advocates, I think needs to be more broadly spread into the professional mental health profession. We have, I think this is my last one, an employer documents that his first verbal warning doesn't, oh, I'm sorry, this is the accommodation for Mina. The employer documents the first verbal warning doesn't rescind the discipline. He does start the interactive practice at this time and asks Mina what she feels would help her meet the timelines of her task. So that's something, the crux of the ADA is to start that interactive discussion so you get the individual involved, because sometimes they know what they need, and they just need to know they have the confidence to ask for it. Jo is a nurse with severe depression who's written up after several verbal warnings for inappropriate conduct. She's placed on a 30-day plan of improvement and warned that if her behavior doesn't stop within the stated time period, she'll be let go. When she hears that, again, all too often this happens, she decides to disclose. And if she had that confidence earlier on, she may not be in this situation, and ask for accommodations to assist in her responding more appropriately to coworkers. Since Jo discloses and requests the accommodations, this employer put the performance improvement plan on hold and until they receive the medical documentation, because they have the right to ask for that, and put accommodations into place, but they don't rescind that discipline that occurred before the disability was known, and that is well within their rights in relation to the ADA. Once the accommodations are put in place, then the employer starts that performance improvement plan, and that is a best practice that we try to get employers to embrace. Jack is an elementary teacher who experienced Temporary extreme fatigue, expected to persist for several months due to the change in medication and onset of winter seasonal affective disorder. He was accommodated with removal of 2 extra duty requirements, job restructuring, which consisted of temporarily removing his early and late bus duties, caused no undue hardship to the employer, and greatly reduced Jack's expenditure of depleted energy. One thing to keep in mind here, if these extra duty requirements were paid, which they often are for teachers when you get extra duty, Jack's salary just went down. So that's something to keep in mind, that individuals need to keep in mind as they're moving through that accommodation process. And self-accommodation and confidentiality. I think this is my last one. Jasmine has been taking advantage of working from home through the company telework policy, which a lot of employers do have. She does so to accommodate her mental health condition, as commuting and the interacting in person exacerbates her condition. She's never disclosed. New management has changed the telework policy and no longer allows employees to work from home more than 1 day a week. She decides to disclose, but of course is concerned her manager will deny, or they will tell coworkers why, which is exactly what we heard in Suzanne's research. This supervisor cannot disclose that another employee has been receiving an accommodation, according to the ADA. Sharing that medical information or information is on a need-to-know basis. The employer emphasizes the policy of assisting an employee who encounters difficulties in the workplace and the need for privacy, and allowed her to continue with that teleworking. And that is about all the time I have. Our contact information is here. Please don't hesitate to reach out. There's obviously a lot more to this, but we had to keep the ball rolling.
So quick background, my presentation focuses very specifically on people who self-identified as having some kind of psychotic disorder. And so I'm sure this is not news to folks in this room, but rates of un- and underemployment for psychotic disorders are extremely high relative to other psychiatric disorder groups. The ASOP 10 study, this was a British epidemiological catchment study, found 80% of young adults with a first episode of psychosis unemployed 10 years down the line. Supported education and employment is rarely accessible to this group. In the United States, early intervention in psychosis is one of the few places where vocational supports are being made available. Differential stigma, which I think there's time for discussion, might be something to come back to, as you know, other folks on the panel are maybe looking at a cross-section of different psychiatric disabilities. And the project I'm going to be talking about, when Steve was putting this together, he asked me if I had any data on disclosure, and I had to kind of think hard. And so this is actually a study that I really didn't do for publication purposes. This was used to help develop 2 toolkits to support students with early psychosis in higher education. And then another goal was to create a Facebook. Not like the internet version of Facebook, right? But a place where people with early psychosis could go and look at successful adults across a wide range of careers and how they had navigated accommodations, disclosure, education, as well as then, vocational choice. But for this presentation, I'm just focusing on the decisions and experiences of disclosure and accommodations. Okay, so because this was not intended to be sort of publishable research, we didn't ask people for standard demographics, things like gender and race. We did ask about highest degree, so 33% of the sample had a master's degree, 15% had a JD, MD, or PhD. And while we don't know, this could be affective psychosis, non-affective, right? We actually got a very high sample of very successful people, and this is certainly not well visibly known, especially outside of mental health fields. NAMI National was incredibly helpful in disseminating information about this project to all of their chapters, the National Coalition on Mental Health Recovery, and I was a Stanford postdoc at the time, and this is really interesting. Stanford sent it out, or let me send it out, to all staff, to the all staff list, and a very significant percentage of this sample comes from Stanford. I also got a number of calls from very high-level Stanford people who were unwilling to fill out the survey. They were so concerned about the risks of disclosure, even though it was anonymous, because they had unique, very high-level career paths that they could not, lay out in their responses without the fear that that would disclose them. So really, really very surprising to me. So everybody was an adult with current or past experiences of a psychotic disorder, and they had to self-categorize as having had or having a successful career. All were working full-time or in a few cases retired, and some were full-time Ph.D. students. So disclosure types. So we looked at disclosure both in the context of college or university and work, and for some people that was the one and the same because they were professors or researchers, and coded this into 3 categories. Broad disclosure, meaning there's nobody in their life who doesn't know. They're out professionally, maybe they've published a book, they speak. If you Google them on the internet, you would quickly, learn that they had a psychiatric disability or psychosis specifically. Selective, they're selectively disclosing to just a subset, and this could be classmates, advisors, coworkers, or supervisors. So not selective family disclosure, this is still all within a school or work setting. And then none, absolutely no disclosure, they're not telling anyone. Just looking at the little pie chart, 54% fully disclosed, 25% was selective, 21% disclosed to no one. And when we look at this by career type, I think this is this gets more interesting. So the vast majority of those who disclosed were peer specialists. And actually, we really kind of wanted to get away from peer specialists in this project, in this sample, because more of the point was to document people's trajectories and careers either at a higher level, master's and beyond, or in non-mental health fields. And of course, many of the peer specialists reported this is a condition of our job. Of the few, there was one engineer who had published a memoir, and then everybody else was in mental health fields and explicitly noted that while they were publicly disclosed, that they had very mixed feelings about it. Selective disclosure, then 25%. Here we now start to see more of the other professions coming in. And then non-disclosure. So the only 3 mental health field folks here were a professor of psychology, a therapist, and a case manager. Everybody else was from non-mental health disciplines. Some of them in their comments explicitly noted that, well, for somebody in a mental health area, it might not be so bad to come out. In our area, there would be absolutely zero understanding. So who was the selective disclosure to? So it was all over the map. So there was administrative disclosure. This was typically when somebody was hospitalized. They had no choice, but it was explained to, let's say, their supervisor or their university sort of what had happened and why. Some disclosed to coworkers and or other students who were friends, specifically those who were friends. So even though they were working with them, it wasn't sort of disclosure outside the boundaries of kind of that kind of friendship relationship. 4 out of 17 to coworkers, or what they described as sympathetic supervisors, and then some to sympathetic faculty within an academic program. Experiences. So I already talked a little bit about the broad disclosure category, selective disclosure, most people reporting both good and bad experiences, most describing a very careful selection process of trying to figure out or feel out who it might be safe to disclose to and how they might respond. And then non-disclosure, so just kind of some of the reasons. I have some examples here. There would be no benefit, it's not worth it, wouldn't be accepted in my field or area, definitely not okay for an MD. I've never disclosed in school or work due to stigma. Even among mental health providers, there are those who blame and shame. Okay, and then moving to accommodations. So we might think that disclosure and accommodations would go more hand in hand, which is really sort of not how the data play out in this particular sample. So 44 out of the 67, even among those who disclosed, opted not to pursue any kind of accommodations in either school or work. 65 out of 67 were aware of the option to request. They were aware that they could have done it, and this is typically part of the narrative, why they decided not to, not that they had no option. And so these responses were actually a little bit harder to code and categorize. Stigma/perceived risk because of societal or interpersonal stigma being a big one with somewhat sort of messier contours. So just an example, I turned down any disability services offered at all colleges that I have attended. I requested to not be labeled as a student to receive disability services because of the stigma associated with those services, as well as I wanted to be considered as someone just like anyone else who is a college grad. I graduated with honors. Another reason, perceiving that accommodations simply would not be helpful or were not needed at all. So I was an exceptionally gifted student, for example. What disability? My voices are a gift. The accommodations I was offered would not have helped. And then this kind of category in which accommodations really seemed to be in conflict with the individual's self-image as a hard worker, as a brilliant student, as somebody who is talented, as somebody who is making major contributions in an intellectual field or a mathematical field or in medicine. And you really saw a lot of this in, kind of within those people who had doctorate degrees. And, we could sort of think about this in terms of a kind of internalized intellectual ableism. I didn't have any academic challenges while in university. I haven't really felt the need to request something like that at work either. If I don't feel I can perform the role I have any longer, I just try to define a new role for myself within the organization. Since I went back to school, I had psychotic outbursts a few times, and I did miss classes, but I never missed any assignment or project, and I did not want to use accommodations. Okay. So just to wrap it up, disclosure and accommodations are kind of orthogonal constructs as they emerge here. They don't always go together, right? So somebody can be making the decision to disclose, but nevertheless be unwilling to use or ask for accommodations. And sort of part of the reason there to restate being that it does not align with their self-image, or there's sort of some form of stigma attached to accommodations that's not necessarily attached to disclosure. Meaning you can disclose having a diagnosis without the implication necessarily being that you have any impairment, whereas for the accommodation, you're essentially agreeing or conceding that you have an impairment. So I think this would be an interesting thing to take further in the future. And then that professional and work context matters. And again, not really research data, but if it was, I would describe it as, very preliminary pilot data. And, maybe some of Marjorie and Steve's work will be able to help elucidate some of this down the road. And accommodations, that many people are successful bypassing or not using accommodations. And then just finally, to return to the question of psychosis versus other diagnoses, the stigma is substantially greater. What it means to disclose having schizophrenia or a psychotic disorder is a very different thing, and we know this through voluminous stigma research, than, say, disclosing depression. Schizophrenia, because it's a lower incidence disorder, is much less represented in larger, cross-disability or cross-psych disorder samples. And so what are the kind of some of the unique issues that this raises, and that the navigation of psychosis specifically raises, that we maybe need to look into more? There are three concurrent presentations right now that are focused on early psychosis stuff. But again, just to kind of reiterate, these kinds of questions become particularly important in the context of early intervention. We're going to be, soon starting to discharge on an annual basis potentially tens of thousands of young people from these specialized early intervention programs where we've given them a really strong start, but where they're going back to is school and work, and so it becomes pressing. I'm piggybacking on Stephen saying this to NIMH. Right, it becomes really pressing to understand what's happening to them in the context of reintegration.
Okay, well, as Stephen has said, the sixth time was the charm with the grant to NIMH to study disclosure. And I wish I could stand up here and say we have results that will answer many of the questions that Nev had raised, but the grant only began last July. And what I've learned since then is that I knew how to write grants that did not get funded. But I didn't very well know all that was entailed in managing a grant that did get funded. So it's been a learning year for me. But we are up and running and collecting data. So what I have for you today is some information on the pilot study that was part of our application to NIMH and that laid out some of the methods we were going to use for the study of disclosure. And I want to present to you some of the outcomes of that pilot study and then talk about the study that is in the field currently. So I've already talked about what I'm going to do. So the pilot study. 2 research questions basically for the pilot study. First question is, can we identify individual and work-related and service-related characteristics, factors that are significantly correlated with successful competitive employment for workers with SMI? What we know from the literature is that there is a lot of information about supported employment for workers with serious mental illness and psychotic disorders. Much less information about what leads to successful employment in competitive jobs as we have defined them. And we looked at 2 measures of success: employment stability, being able to maintain the job, and gainful employment, being able to support oneself. On a more practical methodological side, we needed to be able to convince NIMH and ourselves that we could identify workers with SMI who are or have been employed in competitive jobs and know that they would respond to a survey on their employment experiences. You cannot do this kind of a study with random dialing because it would be way too expensive. Schizophrenia and serious mental illnesses are not rare, but they're fairly uncommon. And to find people that both had the disorders and were working, the screening costs would just be insurmountable. So this was a huge challenge, and I wanted to talk about how we addressed it. First of all, the conceptual model was fairly simple. We were looking at a number of predictors of employment outcomes. We wanted to consider individual predictors, both that were related to the SMI, such as symptoms, functional limitations, but also more typical that labor economists include in models of employment. Human capital, by that we mean the productive capacity of the individual, the education and training that they've received to prepare themselves for the workplace. We also looked at a set of work-related characteristics. Anne mentioned something about this, as well as Suzanne, that the workplace culture is important and relationships with coworkers and supervisors, so we asked about all of these things. And then we also asked some service-related characteristics, including whether they were taking their medications, whether they were on medication at all. So this was a fairly simple model. And now to the biggest challenge was to find a cost-effective way to find the target population of persons with SMI who are or have been employed in competitive jobs. And this stumped us, I would say, for several years. Finally, the solution came to me actually at a conference where I was talking to a woman who worked for Truven Health Analytics, and she told me about a survey that they conduct every month called the Pulse. And this is a large national health survey. Since then, it's been taken over by IBM, but at the time, it was run by Truven Health Analytics. At the time, they were interviewing 9,000 households per month, 10 months a year. Now it's dropped down a little bit to 7,250. When she told me about this survey, I immediately thought about the problem we were having with identifying our target population, and I said, do you ever let researchers add a few questions to your survey? Oh, yes, she said, we do that all the time. And I said, and could they get contact information for these people who satisfied the screening criteria? Oh, yes, she said. In fact, we ask people if they are willing to be called back for follow-up research. And I remember going home from that conference and immediately calling Stephen and saying, I found a way to find our target population. So that's what we did. We piggybacked on the Pulse survey. They sent us contact information for eligible households. And in our pilot study, we completed interviews with 230 people who had a serious mental illness, which we defined as schizophrenia, spectrum disorders, or bipolar disorder. They were either currently working in a competitive job, as we defined it, or they had worked in a competitive job post-onset of SMI. And again, a competitive job meant it paid at least the minimum wage, and it was not set aside for workers with disabilities. So what I'd like to do is, for the next few slides, present some of the results from the pilot study. Most of these, in fact, all of these results are descriptive statistics. When we parsed it down to the different groups we were looking at, we don't really have enough sample to do regression analyses and control for various factors. That's why we have the major study in the field now, to collect a lot more data and to focus on disclosure. But some of the descriptive statistics we found, 27% of the people we interviewed were currently working in a competitive job, and 3/4 of those were gainfully employed. That is, they were supporting themselves, they were not receiving disability benefits. 52% had left their most recent job for reasons unrelated to their mental illness. They had returned to work, they were doing childcare, or various other reasons. 21% left because of their serious mental illness. So one takeaway from this is that part of the stereotypes of serious mental illness is that, well, everybody knows people with schizophrenia cannot work. And that's just not true. Contrary to the stereotypes, people with serious mental illness whose symptoms are reasonably well controlled can work, and many are capable of supporting themselves in mainstream competitive jobs. And this is a really important outcome to study. As anybody knows who studied our social insurance programs, SSDI, mental illness, is one of the most prevalent populations receiving SSDI. And as those programs become more precarious in their funding, it's really important to find out if people with serious mental illness can actually support themselves and get off of SSDI. So this is a really important outcome. The people we interviewed had a range of occupations, just as Nev said. Some of them really high level, nurses, teachers, accountant, lawyers. Some in service occupations, cooks, cleaners, home health care workers. Some as salespersons, cashiers, receptionists, some in construction workers. Among the population of persons with SMI, there are persons with the skills and abilities and interests to hold almost any job in the economy. In some of the research that I did for my book, I read comments from people with SMI whose healthcare providers told them, oh, you couldn't do that job, not with your illness. And one message I'd like to get out is people with SMI should not be discouraged from following their dreams. Many can and will succeed in competitive jobs, even fairly high-level ones. Two groups that we were really interested in comparing were those who were currently employed in their jobs, which we called the stayers, they were staying in their jobs, and people who had left the job because of their serious mental illness, leavers, so that they were not successfully employed in that job. And we had 61 people who were currently employed and 80 who had left their jobs, so you can see the sample sizes get fairly small. But we compared them according to their functional limitations. We asked them if they had difficulty with certain tasks that might be impacted by a mental illness, such as concentration, remembering to do important things, and so forth. And if you look at this slide, you will see that for every single functional limitation we're looking at, the people who left their job because of SMI were more likely to report that they were limited. However, what's really interesting is the people who were currently successfully employed and working in competitive jobs, they didn't say that they were symptom-free. Many of them reported symptoms, difficulty concentrating, difficulty with memory. So what these suggest is that it's not necessary to be symptom-free to be successfully employed, but those with fewer symptoms seem to have more successful work outcomes. Many of you have probably heard of Ellen Sachs. She's a professor at, I think it's UCLA, and has written a book about her experiences with psychosis, and she said she still hears her voices, but work helps to keep her symptoms at bay. In other words, work actually facilitates the recovery. I said we looked at human capital, and I think there's a lot of lessons here when we look at education and work experience. Fairly high levels of attendance at college across our sample, and I think that's in part because across a wide range of disabilities, education, in economists, sometimes health economists call it insurance against disability. Education gives you a range of jobs that you can do even if you encounter a disability. And so I think because we're looking at people who had experience with competitive employment post-onset, we're getting a selected sample of people with higher levels of education. When we compare people who were currently employed versus people who left, we see that the currently employed people were more likely to have found some way to finish their degree. 46% of those who were currently employed were college graduates, only 23% of those who left their job. And among the currently employed, 20% had been able to complete a postgraduate degree. We also asked about supported employment experience, and it's interesting to see that 20% of those who were currently employed seem to have graduated from supported employment into independent competitive work. And it seems that supported employment does perhaps facilitate that, but 80% of those who were currently employed had never had an experience of supported employment. So I think another lesson is that supported employment is really important for a subset of the population of people with SMI, but it's not the be-all and end-all, and we need to do a lot more research on other alternatives to supported employment for the people who are capable of that. Here might be a slide that surprises you. Among those who were currently employed, 75% said they were taking their medications as prescribed, compared to 90% of those who left their job because of SMI. So there was fairly good adherence to their medications here, but better adherence among those who had not been able to stay with their job. We asked if they were not taking any antipsychotic medications at all, and 20% of those who were currently employed were not taking medications, compared to only 6% of those who left their job. This may seem strange, but there is support for these findings in the literature. In 2012, there was an article published in Psychological Medicine, Do All Schizophrenia Patients Need Antipsychotic Treatment Continuously Throughout Their Lifetime? And the authors found that not all schizophrenia patients need treatment continuously throughout their lives. They found a group of schizophrenia patients not on antipsychotics for prolonged periods. They found that this group seemed to be a self-selected group with better internal resources who somehow found that they were able to function without the antipsychotics. And that seems to be what we're finding in this 20%. I'm not standing up here advocating for people to go off their medications. I'm just saying that for some people, they can go off their medications and they can have fully functional lives. Requesting job accommodations. It's not surprising that among those who left their job because of SMI, there were a higher percentage who had requested accommodations, 35% versus 26%. This is not surprising because we saw that they had more limitations. I think it's really telling that 100% of those who are currently employed received the accommodations compared to only 50% who did not. Okay, so is this counting down my seconds till I have to be quiet?
It's counting up your seconds now. It's running over.
Oh, no. Oh, it's a guilt meter. Oh dear. How are we for time? I want to make sure we have time for Renaud and for questions.
You have about 13, 14 minutes left.
Okay. I'm just going to very quickly skip ahead to say that we did not collect much information about disclosure. And when I started to write the book my book, every single chapter, I found a deluge of research that I had to read through, weeks and weeks of reading through research. But the chapter on disclosure, there really was literally no systematic research. There were studies like NAVS who had gone out to look at work experiences, and collected information about disclosure, but no systematic research. That's what our project is all about, and we are using the same pulse study to collect our data, and after I learned how to manage the study and got all the contracts in place, we are collecting data. So I hope to come back in a few years with answers to some of the questions that Nev raised on disclosure. But I'm going to stop there, and so we have enough time for Renaud and questions.
I'm going to shut this so I can put my computer down. Hopefully you guys don't mind. I don't have slides. Sorry. So I found this to be a very exciting panel on disclosure of SMI in the workplace. I think our panelists did an amazing job setting the agenda for a robust research agenda on the topic. I want to first start by making a few disclosures of my own. So this is not a topic that I have content expertise in, and I'm really humbled by what I don't know and learned a lot listening concerns as they conduct this important work. Questions?
There we go. All right. It's going to accommodate small people. So I've got a mess of stuff in my mind, and I'm not sure what's going to come out of my mouth first. But my name's Leslie Kaplan. I'm from the National Institute on Disability, Independent Living and Rehabilitation Research. And we have, in our 40 years of existence, always funded research on employment for people with disabilities. Suzanne referenced the 4 grants I think that she's had. I was the project officer for 2 of them. Nev has 1 now, actually. And it's interesting seeing how the difference in perspective from the funding organization affects the questions you ask and the way you hear things. This would have been an easy NIDLR workshop, no problem, every single one of them. We have several, I can think of 2 different grantees working in mental illness who use the Truven, for example. And our assumption is that we have people with disabilities in the world, psychiatric disabilities, I don't even know what to call them anymore, physical disabilities. Nev and I have had this conversation. And they have those disabilities. We're not going to fix them or cure them, but they have the right to be able to live the lives they want to live in the community. And how can we gather, do research, give ourselves information, and promote the use of that research to allow them to do that? And when you listen to employment research through that lens, it's really a different question. I really share Nev's concern about all those folks who are coming out of the first episode psychosis programs, because I worry, I mean, we have grantees who do research on transition to employment in young people with serious mental health conditions. We have grantees who do research on employment adults with mental health conditions. And some of the things they look at is how you prepare those people to get out in the world and have jobs and be successful and understand what they need to do for themselves, and also what the organizations need to do to support them. So I just like to suggest maybe a little cross-agency talk sometime, both agency to agency and researcher to researcher. You know, I can put you guys in contact with folks who do related work. One of our researchers has a help guide out for faculty members with mental illness, how they should function in that space, how universities should accommodate those needs, the relevant questions. So it's just an offer for conversation in various ways, because I think we have a lot we could learn from each other.
Thank you. Yes.
I had a question for Anne. Thank you for letting us know about a resource I was previously unaware of, embarrassingly so. I had a question about how you handle referrals, and if that is beyond the scope of what you do. So with the PTSD example with the nurse, I was thinking this is her dream, this is my psychologist talking, but this is her dream job and she can't handle it because of her PTSD symptoms. In addition to counseling her about accommodations, do you also make referrals or try to connect her to treatments?
Yes, we do. In that situation, she was in treatment. And that's, I mean, she had it in her head, this is not always going to be this way. But her treatment provider really didn't know what to tell her about what her rights were, or how to move forward. But yeah, we do try to make referrals as best we can. We use different state resources, sometimes independent living centers or other resources to try to get a referral as close to that, where that person is within that community.
Thank you.
Another question over there? There was, yeah.
This question's for Dr. Nev Jones. I really enjoyed your presentation. I thought the project was really interesting in the way you collected narratives. I was just wondering how are you disseminating the website? Who is the website disseminated to? Is it something publicly available? And since you work with youth in early psychosis intervention programs, have you done any research measuring their reaction to the narratives or collected measures of self-stigma, or even then kind of thinking about how, you know, there's different levels of disclosure and resources. So on one hand, young people might get messages that they should disclose in the workplace to ask accommodations, and they will get other messages where people will say, this will hurt your career chances, don't do this. How do you see this kind of building, or have you thought about how you react to these types of narratives and how to plan their career paths?
Yeah, a little embarrassingly, I mean, that was the goal. So I developed under the National Technical Assistance Funds associated with the SAMHSA Mental Health Block Grant set aside for early intervention a series of 2 toolkits, and there's briefs, there's summaries of the data from this project in there to sort of make the case to young people. The next stage of that project, so not just, this was originally called the Success Stories Project, that and the toolkits, I've turned them into a series of trainings for different types of staff in higher ed settings, as well as for early psychosis providers. Would like to eventually do youth and family workshops, and those, and that I think becomes the part where then I start to be able to really sort of evaluate impact, is through doing those trainings and look at whether this is actually changing practices around accommodations and faculty kind of willingness to support students with early psychosis. In terms of youth themselves or young people in early psychosis programs, that would be another thing to do, but I think only once it's more developed. Now, a colleague of a lot of ours, Pat Corrigan, has developed a disclosure decision-making intervention called HOP, Honest, Open, Proud, and working with one of my new faculty colleagues, one of Pat's students, we've been discussing kind of a combined intervention that would be, right, honest, open, proud, so a structured process to think about disclosure, then paired with a sort of a navigator component to actually enact that and to be sort of coached through actual disclosure, and then pulling in some of these other elements. So I think it's not ready. A sort of a Facebook or a booklet itself isn't enough. It was all up. The toolkits are all over the internet. We did actually had a dedicated website for a while and then took it down because I wanted to sort of develop all of these other components. But thank you.
How are we for time? 30 seconds. Does anyone have a 30-second question?
I'll try to make it quick.
Okay.
So my question is actually for you. I thought your point on medication adherence was really interesting, and my question is more if there's been studies around weaning people off of their antipsychotics and symptom control. And perhaps this is too clinical for this, venue, but
that is really a clinical question. I don't know if there have been studies on it. I know from my own personal experience, the book is about my son, and my son has been off his meds for 10 plus years. And when he went off his meds several times, he relapsed. When he finally did it successfully, he did it with his psychiatrist and weaned him off gradually. But that is absolutely, obviously, that's just one example. But I don't know, maybe if there are more clinical people here who know about if there's research on this. Mike, maybe, do you?
There are 2 RCTs, 2 full RCTs, one happening in the UK recently started, one in Northern Europe. There is a recently published coming off med study that was in psychiatric services. Will Hall and Jim Van Oss at Maastricht University are doing a massive coming off psychotics research study right now, which is more looking retrospectively at people's experiences, whereas the 2 RCTs are actual discontinuation trials. Lex Wunderink has also published a randomized control trial with, I think at this point, almost 10-year follow-up, where first episode youth and early psychosis programs were actually randomized to discontinue or not. And so there's definitely in the early intervention space in particular quite a lot going on to look at discontinuation and to try to identify this subgroup of young people who do seem to be able to do well and in fact do better because you're removing the burden of antipsychotic side effects. And I think pretty much the consensus would be it's not everyone, but there's sort of a subgroup who does, you know, totally fine off them.
Thank you all for coming.
So whoever was saying how wonderful a resource JAN is, they are. NIDLR also funds an ADA Technical Assistance Network, and Suzanne had one of those in her list of grants. It's adata.org. We have 10 centers around the country. If you have questions as a supervisor, what am I supposed to do? What does the ADA say I should do? Or if you have questions as an employee, or if you can't get into your local supermarket, if you have questions about what the ADA requires or what you should do,